Hi, my name is Nathan Varady on behalf of Drs. Antonia Chin, Eric Smith, and our entire team. I'm really excited to talk to you today about our recent article in JBJS entitled Opioid Use Following Inpatient versus Outpatient Total Joint Arthroplasty. And so with the increasing use of outpatient total joint arthroplasty, we wondered whether encouraging patients to go home on the same day as surgery or to keep patients from being concerned about their pain regimens, maybe to prevent them from calling offices, whether that might incentivize surgeons to increase the amount of opioids that they prescribe. In addition, outpatient arthroplasty has received considerable attention across various outcome metrics from arthrofibrosis to DVTs to readmissions. But it's then unclear whether there may be adverse events related to the evolving analgesic regimens related to these surgeries. And you could imagine that this might be the case. Maybe patients aren't monitored for that initial 24 hours and maybe take more pain medicine, which could potentially increase their risk of long-term opioid use. Or alternatively, you could imagine that maybe patients are more comfortable at home, maybe more hesitant to take opioids in an unmonitored setting, and thus potentially lowering the risk of long-term opioid use following arthroplasty. And so the purpose of this study was really to investigate both the prescribing practices writ large, and then on a patient level, whether there were any differences in risk of long-term use. So we were surprised to see that the total volume of opioids prescribed did not differ between inpatient and outpatient arthroplasty. Both had a median script size of about 750 morphine milligram equivalents. Opioid prescriptions writ large were slightly less common in the outpatient setting, but that could easily be due to patient factors. But when prescriptions were written, we were surprised that the outpatient scripts were the same size, because you can imagine that the inpatients have one advantage, which is that they receive at least some of their initial opioid doses while they're in-house. And so the outpatient script that's ultimately written for potentially should be even lower than the outpatient setting. In addition, pain is one of the most common reasons that patients call orthopedic surgeons' offices after outpatient arthroplasty. And is also one of the biggest fears to patients actually undergoing arthroplasty. And so again, it would have made sense to us that if script sizes were potentially a little bit larger in the outpatient relative to the inpatient setting, but they were not. They were basically the exact same size. Encouragingly, we found that the outpatients had a slightly smaller risk of developing long-term opioid use, both overall, but then just among the patients who received opioids, those who, in both groups, those who underwent surgery in the outpatient setting after adjusting for the confounders that we could, had a tiny bit lower risk. I wouldn't interpret this as saying that outpatient arthroplasty reduces the risk of prolonged opioid use, defined as still filling opioid scripts 90 days after surgery. But I would say that it certainly supports the fact that outpatient arthroplasty is not increasing the risk of long-term opioid use. And so to the extent that that reassures the field that this transition to outpatient arthroplasty isn't reversing any of our progress that we've begun to make on curbing the opioid epidemic, at least orthopedic surgery's impact on it, outpatient arthroplasty is not exacerbating that or making it worse. If anything, it might be beneficial, but probably pretty similar overall. Moving forward, I think the biggest outstanding questions are, one, this wasn't a randomized trial, and now it's what you would really need to definitively prove that it reduces. But two is, it's encouraging that about 20% of outpatients didn't need opioids at all. And so I think that raises the question of, how few patients really do need opioids? How low can we go? Can we eventually eliminate opioid use after arthroplasty? It was really interesting for us. One of our reviewers worked in France on this paper, and his or her feedback was that this is crazy. They only prescribe opioids to arthroplasty patients maybe 1 to 3% of the time over there. And so that really stood out to us, and I think is the most exciting question moving forward is how low can we go? Can we eventually have opioid-free arthroplasty? And if not, then how do we identify the patients who really need it and who may be at the most risk of developing that prolonged use? So thank you, and feel free to reach out if you all have any questions about the article. Take care.